Yeah, I think you all can. Um, okay. So this is the 33rd repeat. Like as I 9th batch, 8th batch, they had their repeat. This is the surgery 33rd paper, right? So it's not made properly, but anyways, we have the question properly, so that's fine. Okay, so this third question is essentially, this is the only question that I have actually come across where they are asking more or less on the right hypochondriac pain and those stuff, right? So we'll just briefly go through the questions and we'll go through the theory and we'll try to answer this question by the end of it. That's fine. Okay. So y'all can y'all just let me know just on the chat. Just say that y'all can see the screen and can y'all read the questions properly, because otherwise just say yeah or something. Can y'all see the screen and read the? Okay, cool, great. Okay. So this third question, yeah, the 50-year-old woman presents with a 3-month history of recurrent right upper abdominal crampy pain, which lasted for about 2 to 3 hours, right? And is associated with nausea, especially following fatty meals, right? And she has no loss of appetite and or loss of weight, right? So they have asked 6 questions, and they have asked the likely diagnosis, the most appropriate initial investigation while giving reasons. And to list different complications that can arise due to the above condition, and you have to briefly describe the pathophysiology of those. And what is the definitive treatment of the condition mentioned? The 2 important aspects in preparing this patient specifically for the above treatment, and what is the most serious specific complication of this treatment, right? So now this question essentially covers the entire theory of right hypochondriac pain and related conditions. If we can answer this question by the end of it, it's perfect. You all have covered what is necessarily what you need to know about the right hypochondriac pain and related cases, right? So I will just show you all the now. I'm sure most of y'all have come across this note. If y'all haven't, that's fine. So this note is my note that I edited from Barnagalas's note. So now this covers most, but not all of what's necessary for you to answer that specific question. So um, I will add the additional points that y'all need. I will add while we go through the theory. All right. So because this covers MCQs and SPAs as well as the SCQ, the long case part. So we'll go through it, right? Okay. So MCQ parts I will just highlight when y'all need. Okay. So now this the gallstones. Now right hypochondriac pain gattahama, right hypochondriac pain is essentially, whenever you get a right hypochondriac pain, you just need to kind of get into your head what exactly could be the reasons for this hypochondriac pain. Okay, I think we lost about 12 uh, the okay, never mind. We people have gone, yeah. Okay, never mind. Okay, so yeah, all right. Now gallstones gattahama, the gallstones anyway, right hypochondriac pain gattahama, the right hypochondriac pain will essentially it will cover mainly the gallbladder related case, right? But if they were to ask you what would your differential diagnosis be, right? Because that's what they asked me uh when I was given that case, right? That you have to consider all of the things that you might get in that particular region, the right hypochondrium. You have to consider all of the things, right? So now my case, I will get to in a bit because we'll go through the theory first. Now, gallstones, I'll just briefly run through this note. So gallstones, this the where you get more commonly, you obviously have come across this part, the fat pair fertile females of age 40. So they tend to ask this. Even in SEQs, they can just give that description of a woman who fits this description to, or SPAs, you can get that description of a woman so that you will be directed more towards gallstones if they're asking that. So just remember that these people have a higher tendency, and we'll get to why they have that in a while in the next page. Fair, of course, I don't know why, but still, yeah. And how do you identify a gallbladder? Now that part, of course, they have they can ask that in a short case, right? Because as you all know, in surgery, you do have a rare short case where you can be given an abdomen to do an abdominal examination. In that case, they can ask if you were to think that this is the gallbladder, which is if you found a mass there, ඒක gallbladder කියලා හිතන්නේ ඇයි කියලා they might ask, right? So in that case, you just have to say that this is in the right hypochondrium in the abdomen, that it is globular in shape. You might be able to feel that it's globular and it moves with respiration and it's continuous with the liver කියන එක. So that is theoretically, that is why you would consider a, a mass in the right hypochondrium as um, related to the gallbladder. The gallbladder has swollen. Okay. So now this main constituents of bile and steps of gallstones formation, highly unlikely that they will ever ask this. Just remember the main constituents of bile, just cholesterol, bile pigments part එක එච්චරම ලොකුවට අහන්නේ නැහැ ඒක නම්, right? Just remember that part. The types of gallstones you definitely need to know, right? That the things that I've highlighted are the main things that they may question you all on, right? So the pure cholesterol stones, the pure pigment ones, and the mixed ones. You all should know that the mixed ones, that means the cholesterol pigment mixed ones, are the commonest types of stone, right? And that the cholesterol ones are very large. They usually tend to not leave the gallbladder. They tend to stay in the gallbladder, whereas the pure pigment ones, they can lead to other conditions related to the gallbladder or the gallstone leaving the gallbladder, right? So now one main thing you have to remember is that these are radiolucent, right? What does that mean? Radiolucent කියලා කියන්නේ you will not be able to detect these in an X-ray, right? Because if you all remember, the urolithiasis, the urinary stones, those are the main ones are radio opaque. At least 80% of them are radio opaque, which means most of them will be caught up in X-rays, right? Unless, of course, you've come across them being in very precarious positions over bony prominences or something, you will most likely be able to detect them through an X-ray. And the opposite is how it is with gallstones, where in which they are radiolucent. You won't detect them in X-rays, right? Most of them won't be seen. So that's something that you have to remember. Okay. Okay. So now this, as I can't remember whether we were asked this, but factors predisposing to stone formation is something that y'all should know. It's a thing that they can question y'all on, and I believe that was also asked from me in my long case, right? But obviously you have to correlate this to your patient. If you were given a right hypochondriac pain long case, you have to correlate that with your patient and tell what exactly you found as possible risk factors for this woman or patient to get gallstone, right? So generally speaking, may reasons තමයි what you get as causes for gallstone formation. So like increasing age, obesity, the diet, estrogen, oil, ඔක්කොම what they do is they increase the cholesterol content of the body, right? So why is that important? Because pure cholesterol stone is a type of gallstone. So if you were to increase your cholesterol intake or the cholesterol, the level in your body, you are at a higher risk of getting a cholesterol gallstone, right? So that either it may due to increased age, right? Your obesity itself, it will increase the cholesterol content in your body. Diet consisting of fatty meals and whatnot will increase your risk of getting cholesterol gallstones. And estrogen. That is why estrogen has a higher level of it has a higher risk. The fact that if you have more increased estrogen in your body leads to a higher level of cholesterol related gallstones in the body, which is why you have higher level, right? The female gender. You might even get pregnancy. වලදී එන්න පුළුවන් gallstone related disease, right? And if you're taking OCP, same thing. Okay. Then TPN, long-term parenteral nutrition, right? If you're on some long-term parenteral nutrition due to some gut surgery, or if you're having cancers or something like that, right? It can lead to a high risk of gallstone formation. That is mainly due to the fact that මොනවද මේ, uh, because y'all remember that there is something called cholecystokinin pancreazyme enzyme that it stimulates the gallbladder to release the bile from it. So when there's bile stasis, you might get stone formation because the stimulation from the CCKPZ is not there when you're not eating from, like, when you're not having any oral intake and your entire nutrition is sent through the IV. That's what happens in TPN, right? Also, it has a effect on altering the bile constitution. Okay, so now we know that the bile constituents is the cholesterol, the bile pigments, bile salts, and phospholipids. Those are the things that are necessary for the bile formation. AK constituents venas වෙද්දී, there is a higher risk of forming gallstone, right? Okay, so yeah, okay, so then diseases involving the distal small bowel. Why? Because the enterohepatic recirculation, as you all are aware, there is something called enterohepatic recirculation, wherein which they take up the bile that's secreted up, and it is utilized again to form bile, right? And if you don't have that, there is the if the enterohepatic recirculation is affected, then there is a chance that they have more risk of gallstone formation because the bile formation is now increased, right? So it has to continuously make bile as opposed to reusing it, right? So Crohn's disease වගේ ඒවා හරි නැත්නම් terminal ileal resection එකක් මොකක් හරි එකක් වුණොත්, right? For some reason, if you were to surgically remove the terminal ileum, then you have a high risk. So as we mentioned, gallbladder stasis, that's due to TPN hari මොන හරි දෙයක, you can get high risk of gallstone form. Multiparity, that's mainly like if you were to have pregnancies, like multiparity. Again, that's because the levels of the hormone levels can affect your the gallbladder, the contraction, the stimulation, and it can lead to gallbladder state, right? Okay, right. Chronic hemolytic disease is the reason for pigment stones. Just remember that. That's the reason why you might get like the hereditary spherocytosis, so even the rarer hereditary elliptocytosis වගේ දේවල්, those lead to higher levels of hemolysis in the body. So hemolysis means you get more pigment formation, right? The bilirubin, biliverdin, bilirubin හැදෙනවනේ. So that leads to higher levels of pigment stone formation if you were to have a chronic hemolytic disease. Okay, all right. So now this entire table is basically giving you all an idea as to what you might get due to the gallstone formation, and what you get will depend on where the gallstone had gone and obstructed or caused some complication. Okay, so now you know that the gallstone forms inside the gallbladder. Gallbladder එක ඇතුළේනේ හැදෙන්නේ ඕක. හරිද? Now, where does the bile form? The bile exactly doesn't form inside the gallbladder. It forms inside the liver. Liver එකේ bile caliculi and all that. It forms the bile, goes through the hepatic duct and the common hepatic duct එකෙන් ඇවිල්ලා it goes down the common bile duct, right? And it will eventually enter the cystic duct and go into the gallbladder where it gets stored, right? So then the gallbladder එක ඇතුලේ stagnate not bile, it can form gallstones. Now, if it were to form gallstones inside the gallbladder and it stays inside that, then these are the things that can happen inside the gallbladder, right? ඒ ටික තමයි හැදෙන්නේ. These are the complications, clinical entities that you might get if the gallstone were to remain inside the gallbladder. So you might get biliary colic. And we will talk about what these are. Biliary colic, acute cholecystitis. You might get a mucocele, empyema of the gallbladder. Even a carcinoma, very rarely, carcinoma of the gallbladder in the pool. And what Miritz syndrome is, I'll touch on that as well. Now, if this gallstone were to remove itself from the gallbladder and go into the duct, especially the common bile duct වගේ එකකට ගියොත්, sorry, not the common, yeah, common bile and the common bile duct හරි the common pancreatic duodenal duct එකට හරි ගියොත්, හරිද? Then these the ones in the middle are the complications that you will, the clinical entities that the patient will present, right? So you will get obstructive jaundice, or you might get acute cholangitis, or you might even get pancreatitis. So you all attended a class done on pancreatitis yesterday. So one reason for pancreatitis is gallstone. Okay. Now the other one is if it were to go into the bowel. Now this is a complication that you don't, again, you don't need to know this thoroughly, but knowing this is good, because if you were to say that if in your long case, you will actually, they will be quite impressed that you know this, right? So now gallstone ileus කියන්නේ, if your gallstone were to stay inside the gallbladder for a long period of time, right? So this gallstone is not inherent to the gallbladder. නේ gallstone එකක් නෙවෙයිනේ gallbladder එක හැදිලා තියෙන්නේ තියාගන්න. It's bile, right? So now the gallstone එක තියෙද්දි it'll tend to erode the gallbladder wall එක. හරිද? Over time. So now this gallbladder in that area, it's quite closely associated with the small bowels, right? The small bowel එකට ලං වෙලා තියෙන්නේ. හරිද? So now when this gallstone, when it erodes through the gallbladder wall, it can form a fistula with the adjacent the small bowel, right? So what can happen is the gallstone එක won't go through the cystic duct and go through the duct. It'll go through a fistula that it created, enter the bowels, and go through the small intestine, right? ඊට පස්සේ it will get it'll get stuck at the smallest part of the bowels, which is the ileocecal junction, right? The ileocecal junction එකේ it'll get stuck. So that will give rise to small bowel obstruction. Your ileocecal junction එක obstruct වුනහම your small bowel gets obstructed, and backwards you get small bowel obstruction. හරිද? So that is a complication, a clinical entity that can happen rarely due to gallstone. හරිද? Now, yeah, okay. Right. Okay. So then we'll talk about the gallstone part, the gallbladder part, because this part we'll come back to that. So in the gallbladder part, so this is essentially a comparison between the two most common clinical presentations of gallstones within the gallbladder, right? So you, in one side, you get biliary colic, the other side, you get acute cholecystitis. Now, you have to know exactly what those two conditions mean, because this was my long case, as I mentioned, and my patient had a biliary colic. My patient did not come with acute cholecystitis, so my case was essentially like they took it along the biliary colic, right? And by the end of it, I actually even forgot a bit for a moment that we were dealing with biliary colic rather than acute cholecystitis, so they had to correct a bit. But eventually, of course, they were fine with all the answers I gave. So you need to know exactly what the difference in between these two are, and not get these two mixed up if you were to get your case in the exam as a long case. That is it. So now these two scenarios that are given at the top, they both refer to the same patient. Only one thing is different, right? So we're talking about a 42-year-old diabetic female presenting with a colicky right hypochondriac pain, right? Radiating to the back. And what is the most likely diagnosis? So on the left side, they're talking about a most likely biliary colic. Now, what is the difference on the right side? The clinical scenario got them. You get the same patient, 42-year-old diabetic female presenting with a colicky right hypochondriac pain, right, radiating to the back. The difference is now she's coming with fever, right? The fever being there in a patient who is presenting with gallbladder related clinical symptoms, right? You get the right hypochondriac pain, which is colicky and all that. If you get that sort of a patient, then if the patient says that she had fever, then you have to consider that this is most likely acute cholecystitis as opposed to a biliary colic. What is the difference? So the difference is that biliary colic is essentially a condition that you get due to the presence of the gallstone within the gallbladder, right? There's no inflammation as such. Just the presence of it leads to all these clinical symptoms. So you don't get any constitutional symptoms like fever, tachycardia, and all that. You won't get them. So if your patient, so in your long case, if you were to get this sort of a patient who says, මගේ බඩ එකක්ම තිබ්බා ඒක තිබ්බේ මේ දකුණු පැත්තේ උඩ හරි තමයි ඒක පටන් ගත්තේ ඒක එනවා යනවා වගේ තිබ්බේ කියලා කිව්වොත්, so now you know that this is very likely to be gallstones, but just in case you have to just ask some urinary symptoms to just you know differentiate from some pyelonephritis වගේ මොකක් හරි නැත්නම් urinary stone එකක් වගේ, හරිද? renal stone එකක් වගේ නොවෙන්න, just ask. But one thing you have to be clear about is you have to ask උණ තිබ්බද කොයි වෙලාවකවත් මේක ආපු වෙලාවෙ ඉඳන් දැන් වෙනකල් උණ තිබ්බද කොයි වෙලාවක. If they do say that, then you have to know that this patient has come with acute cholecystitis as opposed to biliary colic. හරිද? So now the difference is the difference is that you have to the management will differ, right? So all right, so let's talk a bit about the features that they will present with. So now they will present, both of them will present with pain, right, in the right hypochondrium, which is what we're talking about, some topic. So the severe colicky type of pain, like එනවා යනවා වගේ pain එකක්, හරිද? So now you get like spikes of pain, right? Spikes of pain in a background, right? So the background of pain එක නොනවත්ව තියෙන එකක්, but they get like spike, හරිද? Where in which now the intestinal obstruction, either in the intestinal obstruction, you get pain-free periods as well. It comes and it goes. It comes and goes. Okay. So now biliary colic වල මෙහෙමත් තියෙනවා. I think you must have seen that the graph of biliary colic pain, urethric colic pain, and the intestinal obstruction pain. So biliary colic actually it comes and it stays for a while and then it goes away a bit, but then there is a little bit of a background pain, but the pain lasts for a while. The urethric colic, of course, it spikes like the ඒක එනවා ඇවිල්ලා excruciating pain ඇවිල්ලා and then it goes down, but it doesn't actually, like, you don't get pain free periods, you get painless periods and then it comes back up. Here, of course, you do get a pain in the background but when the pain comes, it's not, even though I've said this spike, it actually spikes and it stays. There is a plateau period and then it goes down again. Okay. So sometimes, rarely in the long cases, they actually ask you to draw and show the three different pains, the colic that you get in terms of the abdomen related colics. So you have to be able to draw. Now in intestinal obstruction, you can draw it like spikes which goes down to the baseline. In ureteric colic, you can you can draw spikes which doesn't go to the baseline. And in biliary colic, you can draw a spike which has a plateau period, right? It stays constant and goes down, right? So that's the three different types you can just draw and show if they were to ask that. I believe some in our exams, some people were asked to draw that. So not me personally, but so also this pain will have it has the it actually tends to radiate to the tip of the right scapula. You can actually ask that from the patient to see whether they actually have that. You can ask මේ කොන්ද පිටිපස්සේ උරේස හරියට ඒ හරියට කියද්ද කියලා you can't exactly say pinpoint, and you can actually just ask them. You can, like the long case that you have the patient, you can just tap there or just press there and ask whether make ඇක්කුම එතෙන්න ගියාද කියලා, rather than like trying to word it as to where exactly you wanted the pain to, you wanted to ask where the pain has radiated to. You can just ඒක අතන අල්ලලා කියන්න අන්න මෙතෙන්ට ගියා වගේ දැනුණාද කියලා කැක්කුම. Then you can tell the clinic, the examiners, that the patient complained of the pain radiated to the tip of the right scapula. So now these patients might also present with nausea, vomiting, they might have anorexia, right? And sometimes, most of the time, they actually will complain of this pain being worse at night, right? And the other thing is, there is a they usually tend to present after a large meal or a fatty meal mainly, right? Fatty meal එකකින් පස්සේ තමයි එන්නේ. Now large meal mainly in case of our questions, the large meal part is usually towards an acute pancreatitis part එකට කියන්නේ. Whereas this fatty meal, they usually tend to direct you towards the gallstone part. Okay. All right. So now the main thing you have to know about the biliary colic is that there aren't any other systemic features. It's just the pain and maybe nausea, vomiting, anorexia. They won't have fever. Okay? So when now compared to that, when you go to the other side, the acute cholecystitis part, there you do get the same type of pain, right? So the continuous type වෙන්නත් පුළුවන් සමහර ලාවට, but mainly colicky type pain, which is again aggravated by fatty food, right? Pain, they may complain of the pain being exacerbated by moving and breathing. You can ask that from your patient as well in your long case, right? If this pain was exacerbated by moving or breathing කියලා, හුස්ම ගද්දී වැඩි වුණාද, මේ ඇවිදිද්දි හරි වැඩි වුණාද, මොනවද කරේ කැක්කුමා වෙලාවේ නිකන් ඇල වෙලා හිටියද, you can ask, right? Because if you all know, ureteric colic pains in a patient, they usually rarely stay in bed. They actually just roll around. They try to assume any position that might allow them some pain-free position, but they usually can't. So they tend to almost always roll around. Okay, but these patients, they tend to lie still, and their breathing might also be very shallow. So that you can just ask them whether they try to breathe very slowly to make sure that they don't get the pain. Either nausea, vomiting again, anorexia they can have. Now the thing is, you have to ask, as I mentioned, you have to ask whether they had fever. Okay, Murphy's line. Of course, that's something you can assess in your examination, and they will ask you in your long case whether you will elicited this, and what does it mean and how did you do it and all that. So it's basically what I've written there, that you press your tip of the press down at the region of the the tip of the ninth rib, right? And you ask the patient to breathe deeply. And they, at one point, they will catch their breath. Okay. And that is called the positive Murphy's sign. Now, the thing is, in both these cases, මතක තියාගන්න, there is no jaundice. Cholecystitis or biliary colic are not associated with jaundice. Okay, they are not associated with jaundice. They are only the only the jaundice are, then we are dealing with the complication of gallstones and not acute cholecystitis or biliary colic. Okay, we'll get to the complications in a bit. Now, investigations wise, basically දෙපැත්තෙම ඒ කියන්නේ මේගොල්ලන්ගේ කොහොමුණත් කරන්න ඕනේ the same stuff, right? Because even if the patient is presenting with biliary colic, you might still do the full blood count, the liver functions and all that. And CRP even sometimes you might, and especially liver functions you might want to do, which I will mention why. So ඒක කොහොමුණත් කරන්න ඕනේ, because even though this document says that you only need to do your ultrasound scan, anyways, in a patient who comes like this to the ward, we will do most of these features, the investigations anyway. Okay. So, but the thing is, what they usually ask is what is the investigation of choice, and that is an ultrasound scan abdomen, right? So now I mentioned why exactly, because X-rays, you don't get, you can't um, uh, you can't identify gallstones. They are radiolucent, right? So therefore, what we do is we take ultrasound scan of the abdomen. That is that is the investigation of choice to diagnose gallstone. That is it. So now the reason why we do ultrasound scan abdomen, samahalata they can ask like, what else will you look for when you're doing an ultrasound scan? So if you say stones, and they'll be like, okay, so what else will you look for, right? So now acute cholecystitis, I told you there is inflammation of the gallbladder as well. Okay, they get inflammation of the gallbladder as well. So what will you be looking for? You'll be looking for stones, yes. You'll also be looking for other features that suggest a gallbladder inflammation. So you might look for gallbladder wall edema, right? You might look for any fluid collection around the gallbladder, pericholecystic fluid, right? So that will confirm that this is acute cholecystitis. Then I have green welling highlight කරලා තියෙනවා මම තව කැලලක්, which is we have to assess for duct dilatation. Why is that necessary? Because duct එක dilate වෙලා තියෙනවා කියලා කියන්නේ, that means your gallstone has somehow, it has gone into the common bile duct. Now, what is the problem there? Now we are not dealing with just acute cholecystitis or biliary colic. Now we are dealing with another entity and another complication, which we will have to address definitely before doing any management for these conditions. And I will tell why we essentially look for this. Okay, because that is even asked in the SCQ. Okay, so ඔය ටික අපි බලන්න ඕනේ. Blood culture කරන්න එක, it's not actually, we don't do blood cultures much unless the patient goes into sepsis වගේ ගියොත්. But you do remember that E. coli is technically the commonest condition, the commonest organism that can give rise to this condition. Okay, the inflammation infection එකක් වගේ කියොත් මේකට දැන් now inflammation එනවනේ, the infection එකක් එන්න පුළුවන්. So because of the stagnant bile, so either E. coli ගිහිල්ලා තමයි ඔතන infection එකක් හදනවා නම් හදන්නේ, get fever and all those එන්න පුළුවන්. හරිද? So these patients now, biliary colic and acute cholecystitis, the treatment, the inward treatment initially is more or less the same, but in biliary colic and acute cholecystitis වලට you can just keep them nil oral and anti-fluids දීලා pain management වලට T6 දෙන්න පුළුවන්. හරිද? And you have to plan for a definitive management, right? So now definitive management in a biliary colic is a elective cholecystectomy, right? Which can be laparoscopic or open, but we don't rarely, if ever, that we do open cholecystectomies anymore, because laparoscopy is the gold standard for doing this. So you normally don't go for open unless there are complications. Okay, so now එතකොට මතක තියාගන්න, what we do is an elective cholecystectomy. We are not doing a hot cholecystectomy or interval cholecystectomy. I am stressing this because this is where I forgot that I'm dealing with a biliary colic in my long case, because I told them that I will do an interval cholecystectomy for the patient who actually came with a biliary colic, and they asked me, did you, like, we are dealing with biliary colic, not acute cholecystitis. So I had to correct myself and say that no, what I meant was elective cholecystectomy, not interval. So remember that those are two different ones, right? Because the word interval is is inherent to acute cholecystitis because there's a particular reason why you do an interval. Elective කියලා කියන්නේ අපිට ඕන වෙලාවක කරන්න පුළුවන්, like um we can just give them a specific date and they can come and get the surgery done, right? So there's no inflammation. But anyways, prior to the surgery, we will do the pre-op investigations. You get the consent from the patient, take full blood count, liver functions, renal functions, and PTINR, chest X-ray, and also if they are old, like over 60, even like yeah, every 45, but over 50s, 55 again, you can even do an ECG, right? And prior to the surgery, you give antibiotic prophylaxis and DVT prophylaxis. Right? The antibiotic prophylaxis, mainly you cover the gram-positives and negatives, that is the cefuroxime and metronidazole දෙනවා. IV 24 hours දීලා and then 5 days continue කරනවා. හරිද? Orally. So that's what you usually do for a biliary colic. හරිද? So what I've written here, nil oral, IV fluids, analgesics, elective cholecystectomy කවදා හරි in the near future. And prior to doing the surgery, you get the patient down, keep them the pre-op pre-op investigations ටික කරලා full blood කොයිට කියලා තියෙන ටික, get their consent and anesthetic referral දාලා and pre-op medications dealer, start them on the antibiotic prophylaxis and give them DVT prophylaxis and do the surgery, right? So that is the biliary colic. Now I'll tell you all that in my long case, they didn't this part of the treatment was asked at the very end. They actually asked mainly the theory related to this rather than going through the treatment wise, because that was their least concern here in my case. Okay. Now, in case of acute cholecystitis, essentially the same thing when they come. You keep them nil oral, IV fluids, and G60 and denava. But here, of course, you have to decide whether you want to go for a surgery immediately or are you going to wait at least 6 weeks and then go for the interval cholecystectomy. That, of course, is not up to us to determine what we are going to do because that is up to the surgeon. But of course, they can ask what are the treatment options available, right? Because you have to explain them. We have to explain to the patient what we are going to do, right? So in the meantime, we can give IV antibiotics, cefuroxime, anyway, antibiotic prophylaxis, surgery වලට කලින් කොහොමද? And until the surgery or until their discharge, we monitor the vitals, the blood pressure, pulse, respiratory rate, temperature, urine output. Why? Because they have a risk of going into sepsis. So sepsis යනවද නැද්ද කියලා බලන්න. We just keep monitoring the vitals. හරිද? Cholecystectomy එක කරනවා නම් hot cholecystectomy කියලා එකක් තියෙනවා, which is what we do before now adhesions. You know, remember adhesions form when there's inflammation තියෙද්දි you can get adhesion form. So adhesions කියලා කියන්නේ fibrous tissue form. So මේ adhesions හදෙන්න කලින් අපිට ඕනනම් the surgeon can go in and remove the gallbladder, which is called a hot cholecystectomy. Or what they can do is they can wait until the inflammation has settled, like 6 weeks, and then do an interval cholecystectomy when the inflammation has resolved. So those two, the pros and cons of those two are not necessary for us, right? Because the decision lies with the surgeon. We just need to know what those two mean. Okay, and it is done laparoscopic. Okay, now the investigations වලට I told y'all the ultrasound වලට අපි duct dilatation බලනවා and I also mentioned LFT mainly. Why? Because now this thing actually is not highlighted in this note. This was something that was told to us during our prof, which was asked in the question that I mentioned to y'all earlier. Okay, so uh, all right. So එතකොට one complication that we have to make sure that we don't that we what do you say that we have to assess is we have to make sure that a gallstone has not come out of the gallbladder and gone into the common bile duct. Why? Because common bile duct එකට ගියොත් what can happen? You can get obstruction to the flow of bile. හරිද? Now, why is that a problem? Why is that something that the surgeons have to be are very concerned about? Now, this is something that's not there in the notes. So if y'all are like writing something, just write this part properly or take it into your head and write it on your own words, right? So now what do? What we do is we අපි gallbladder එක කපලා අයින් කරන එකනේ කරන්නේ. We clamp the cystic duct, හරිද? And distal to where we clamp, we cut out the gallbladder and remove it. හරිද? ඒකනේ අපි කරන්නේ. So what will happen? Now a clip එක අපි අයින් කරන්නේ we stick that the clip එකක් හරි stick කරලා හරි මොකක් හරි කරලා we keep that cystic duct clamp. හරිද? Why? Because that duct is, if it was kept open, what will happen? There's no gallbladder, so any bile that comes into gets stored in the gallbladder, then gallbladder එකක් නැති එකේ that bile will leak out of that open end of the cystic duct and leak into the abdomen, the peritoneum. හරිද? So what we do is we stitch it. හරි ඔය clip එකක් තියෙනවා දානවා. හරිද? Now what is the problem? What is the association between that and CBD stone එකක්? This the connection there is if you were to get a stone somehow stuck in the the common bile duct. Now there's obstruction to the flow of bile. A bile ටික කොහාටද යන්නේ? That obstructed bile will somehow end up pressing against that අපි clamp කරලා තියෙන stump of the cystic duct. හරිද? So what will happen? The bile keeps flowing down from the liver. It will get accumulated more and more and more. So pressure within the CBD increases. So pressure එක release වෙන්න පුළුවන් ලේසිම ක්‍රමය මොකක්ද? It will be to through that stump, through the cystic duct එක අපි කපලා තියෙන cystic duct එක හරහා තමයි යන්න පුළුවන්. So what will happen? That stitch can break or that clip can fall, and now the bile will freely flow out of the cystic duct, the stump of the cystic duct, into the abdomen, into the peritoneum. What will happen? Now you are getting the bile leak and going into biliary peritonitis. So that is the most dreaded complication of uh, this condition. That, and if you were to inadvertently, if the surgeon were to inadvertently make some damage to the bile duct system, again you get the same consequence, where in which the bile will leak from that damaged part and go into the peritoneum, giving rise to biliary peritonitis. That is the dreaded most complication, and I'm telling you all this why, because they have asked this in the SCQ, and there is no reason why they can't ask this in your long case. Because this is something that Dulanta sir specifically mentioned to us and highlighted to us when he explained about the this condition. Okay, so take that into your mind as to why it's important and how it happens. Okay? So that is why I have said here that we do an LFT and specifically we do ALP. Why ALP? ALP කියලා කියන්නේ ALP is a marker of biliary obstruction. So in obstruction, ALP levels increase. So if it were to increase, we can be suspicious that this patient might be having a obstruction to the flow of bile due to gallstone having come out of the gallbladder and gone into the common bile duct. So ALP levels බලන එක is absolutely essential in a patient prior to you doing an acute polycystectomy. So as it shows in the future, we have to make sure if a patient comes like this, we have to make sure that we do an LFT and look at the ALP levels to see if if there's any evidence of suggestive of obstruction. Of course, your ultrasound scan will also give you evidence by the duct dilatation. හරිද? ඒ දෙකම මතක තියාගන්න. Okay. So now the complications ගත්තාම again what we have as complications මං කිව්වා bile duct injury is one of the main dreaded complications. So that is the most significant complication that can happen due to a cholecystectomy, not acute cholecystitis, due to cholecystectomy. හරිද? So what can happen is the surgeon might damage the bile duct and the bile can leak and they can go into biliary peritonitis. And they actually can present very early, even on the same day or maybe the next day, they can present with that. හරිද? So for that, you have to like that they will go into like peritonitis. The peritonitis is a life-threatening condition. So you have to resuscitate, give antibiotics. If they're already on antibiotics, you don't need to like you can just give the same antibiotics, continue to give IV. හරිද? And you can do an ultrasound scan and do an urgent ERCP to stent or remove the obstruction. හරිද? Obstruction කියලා කියන්නේ now if gall bladder අර bile common bile duct එකේ gall stone එකක් නම් or but if there is a damage to the bile duct, you can put a stent over that damaged part. හරිද? Now, if it's a small bile leak, again, when you do the ultrasound scan and when you do the RCT just to diagnose, if it's small, then of course it will resolve on its own. But if it's large, then you will need to transfer the patient to a specialized unit where in which they will be able to do the proper reconstruction of the system. Okay. In addition to that, chest infections and the පුළුවන් cholecystectomy වල why? Because we are operating at the right upper abdomen, which is right next to the lower lobe of the lung, the right lung. So of course, the pain might prevent the person from breathing, and of course that the inflammation and the stimulation and all that can lead to infections there, right? And hydrostatic pneumonia can occur because the respiratory movement is impaired. So that's why after these surgeries, these patients are given those the physiotherapy they are given and those instruments given to improve the respiration. I can't remember exactly what the name is, but yeah. And then bleeding in the පුළුවන්, biliary strictures and the පුළුවන්. Why biliary strictures and the පුළුවන්? Because if you were to like වැරදිලා stitch එකක් දැම්මොත් across the common bile duct හරි වගේ එකක් වුණොත්, then you basically get, or not a stitch, like if you were to like when you do surgery, that surgery itself can cause fibrosis to occur and that can lead to biliary strictures happen. හරිද? Then yeah, ඔය ටික තමයි mainly. හරිද? Acute acalculous cholecystitis ගැන නම් honestly you don't need to know them that much about it because it's not a huge thing that they can actually ask. Okay, but just you remember that there's something like that. You can gallbladder inflammation වෙන්න පුළුවන් without exactly having gallstones inside. Okay, all right. So the next one, this part again not very necessary, but we'll talk briefly about it. So the other one is the fact that like the acute cholecystitis තියෙන අයට what are the complications that they can get due to the disease? හරිද? So what they can get is they can get empyema. Empyema of the gallbladder කියලා කියන්නේ now you having pus inside the gallbladder. Now මෙච්චර වෙලා what you got is a biliary colic, which is just pain due to the presence of the gallstone. හරිද? And all the nausea, vomiting and sciatica. And the next one was acute cholecystitis, where in which the stagnated bile got infected, inflamed and infected and all that. Then that led to fever and all those. Now, if you were to get that the whatever secretions within the gallbladder, the bile and all that, if it were to turn into pus, and the pus it starts stagnating inside the gallbladder, now we have an empyema gallbladder. So they will present with swinging type of fevers. එනවා යනවා වගේ fevers තියෙන්නේ. So any abscess or pus collection in the body will present with a swinging type of fever. හරිද? So you have to remember that because liver abscesses, ඊට පස්සේ lung abscesses, if y'all have medicine to do as well. So liver lung abscesses they can present with මොනවද මේවා මේ swinging fever. හරිද? Okay. So empyema is one මොනවද complication. Perforation වෙන එක rare. Gangrene again rare. So cholecystoenteric fistula is what I explained, which is wow, you get a gallstone ileus. Jaundice due to Mirich syndrome, that I will explain now. So essentially, those are the things that we have to know about the gallstone disease itself. So we'll talk a little bit about the gallstones leading to other complications. One is obstructive jaundice. Now, since there is a class on obstructive jaundice, I'm not going to go deeply into it. You'll be taught about it more properly there. But I will ask because this is now my long case එකේ ඇහුවේ ultimately was theory, all regarding theory related to gallstone, which went into complications of gallstones and this Merit, one of the Courvoisier's law and all that. Okay, so we'll briefly touch on that as well. Now, this gallstone part, this part we will someone else will do it. Okay, so I will not go into that much. So we'll talk about the Courvoisier. Now, what is Courvoisier's law? What is now obstructive jaundice කියලා කියන්නේ මොකක්ද? Now, obstructive jaundice කියලා කියන්නේ you have jaundice. Now, jaundice කියලා කියන්නේ you get like this yellow discoloration of the eyes and the sclera and the skin, right, and the mucous membranes. That is due to the accumulation of uh, either මොනවද දැන් obstructive කියන්නේ නැතුව just jaundice කියලා කියන්නේ either due to the accumulation of direct bilirubin or indirect bilirubin in the body, right? Now obstructive jaundice කියලා කියන්නේ due to the accumulation of direct bilirubin in the body, right? Due to the obstruction to the flow of bile and bilirubin along with it, due to some extrahepatic or intrahepatic duct වල මේ obstruction to the flow of the bile through it, right? And along with bilirubin. එතකොට now we have the other one that is the prehepatic jaundice, right? Which is the medical jaundice කියලා කියන්නේ. So that is due to the hemolytic disease. So that is not covered in this in surgery. That is covered in medicine, the prehepatic one. And even the hepatic, like the hepatitis and all that, is anyways also covered in medicine, the intrahepatic one. So the extrahepatic ones are essentially what we deal with in surgery, the obstructive part. Right? So what happens is when you have an obstruction to the flow of bile and bilirubin, either the direct bilirubin or the conjugated bilirubin, the conjugated bilirubin can accumulate inside those in the duct. Right? The duct, we have these I hope you all can see. So these ducts are there, right hepatic duct and the left hepatic duct combining to form the common hepatic duct, and it combines the cystic duct to form the common bile duct. Right? So where duct sticking, where obstruction you will get the bile stagnating within the duct system. So that duct system, වටේ තියෙනවනේ blood vessels, the capillaries and the blood vessels that are there. So the bile, the bilirubin and all that, there's nowhere else to go. So it'll diffuse out through the duct system and get absorbed into the blood. And through blood, it'll go to various end organs, not end organs, like it'll go into the sclera and the skin and cause the yellow discoloration. And it'll also lead to the conjugated bilirubin being released through urine. That's why you get the dark urine. Because the conjugated bilirubin is now going through, because it'll go through blood, get filtered into the kidneys and go through the urine. So it'll lead to another dark urine. And now since it doesn't go through the duct system to enter into the small intestine, it will not convert to stercobilin and stercobilinogen and stercobilin, and so therefore it will not give any color to the stools, which is why you get pale stools. So we have essentially covered the three of the four the presenting features of obstructive jaundice, which is deep jaundice, which is because the conjugated bilirubin going and depositing in the skin and the sclera. That is so deep jaundice. Then they get pale stools because the bilirubin doesn't go into the small intestines to get converted to stercobilin and give color to the stools. So you don't get color in the stools, so you get pale stools. And then it gets absorbed into the blood and gets released through urine, giving the darker color to the urine, which is why you get the dark urine. And the last thing that they present with is the මොනවද මේ the pruritus. That is because the bilirubin the deposited in the skin will cause itching. So ඔය හතර තමයි clinical features when they come to මොනවද obstructive jaundice. හරිද? So you will get to know this again when they do the obstructive jaundice class. හරිද? Okay. So now, what is the relation between the obstructive jaundice and gallstones? Because obstruction to these ducts can occur due to gallstones. Gallstone එක මේක ඇතුළට යන්න පුළුවන් because gallbladder එක ඇතුළේ තියෙන, it can go through the cystic duct and it can get stuck anywhere in this duct, somewhere in the methanampular plate එකේ and may obstruct වෙන්න පුළුවන්, or anywhere in the CBD, or anywhere in the cystic duct and cause obstruction to the common hepatic duct as well. I'll tell you what that means. So anywhere in that duct system, it can get stuck and lead to obstruction. So that leads to obstruction of the flow of bilirubin and lead to මේවා මොනවද මේ obstructive jaundice. So what does this Courvoisier's law mean? Courvoisier's law කියලා කියන්නේ, in a patient with obstructive jaundice, if the gallbladder is palpable, when you examine and you feel that the gallbladder is there, then it's unlikely that the jaundice is like due to gallstones. Why? Because when there's gallstones inside the gallbladder, I told you all, it will cause inflammation. Inflammation una tangwala, what is the outcome? It's fibrosis. So fibrous una deval, are they large or small? They're small, right? They get contracted. Fibrous they are small. So a gallbladder will it be palpable in case of a gallstone leading to obstruction? Then gallstone එකක් ගිහිල්ලා obstruct උනායි කියලා කියන්නේ මේ CBD එක ඇතුලේ. That means there are some more gallstones within the gallbladder, right? One of them have gone through the CBD and caused obstruction. So that obstructive jaundice is what they're presenting. But since the gallstone is the reason for the obstructive jaundice and the gallstones originate inside the gallbladder mainly, that gallstone will have caused inflammation in the gallbladder to a point where it will cause the gallbladder to undergo inflammation and fibrosis. So the gallbladder won't be palpable. So that is the law. The jaundice තියෙන කෙනෙක්ගේ gallbladder එක palpable නම් it's not going to be due to gallstone. It's going to be something else. හරිද? දැන් එකෙන් කියන්නේ gallbladder not palpable නම් most likely gallstone. If it is palpable, most likely carcinoma. හරිද? Gallstone එක දැන් මේක මම කියලා තියෙනවා මෙතන මම කියපුවම, if it's due to gallstones, gallbladder will not be palpable as not distending, because gallstone came from gallbladder, and the gallstone formation within the gallbladder causes chronic inflammation and fibrosis of the gallbladder wall. Essentially what I just said. So a fibrous gallbladder will not distend properly. ඒක තමයි law එක. And you need to know the exceptions to the law. What are the exceptions to the law? That so now the other way around is, if you get a carcinoma, let's say you get a carcinoma in the head of the pancreas, the pancreas pancreas head of the carcinoma head carcinoma එකක්, this obstruction will occur here. There aren't any gallstones here, it's just an obstruction here. So this obstruction will lead to back pressure on the duct system, and eventually the gallbladder will get filled with bile and it will distend. The bile hari මොනවා හරි එකකින් distend වෙලා it will be palpable. So in case of a carcinoma එකක් තමයි you will feel the gallbladder being palpable. That's the law. But what are the exceptions? Exceptions tamai when the gallbladder is palpable, but the condition, the obstructive jaundice is still due to gallstone. Right? And there are three conditions where the gallbladder is palpable and it's still due to gallstone. What are they? One is if it's a primary CBD stone. How rarely within the common bile duct itself, you can get gallstones forming. Now, it doesn't necessarily need to be only within the gallbladder. It can be within the common bile duct as well. ඒකේ ඇතුළේ එකක් හැදුනොත් the common bile duct එකේ හැදුනොත් gallbladder එකේ inflammation එකක් වෙන්නේ නැහැනේ. The gallbladder won't be inflamed. Ultimately, it won't be fibrous, but there is a gallstone obstructing the bile flow. So you get obstructive jaundice. But your gallbladder is not inflamed, so it will not be fibrous, so your gallbladder will be palpable. Right? That is one. What's the next one? The other one is two stones, just in case. Right? Just in case හිතන්න two stones තියෙනවා කියලා එකක් තමයි one stone has gone into the CBD. Right? It leads to obstructive jaundice. Right? The other stone has it's gone into the cystic duct. Right? And it leads to acute cholecystitis. Right? මතක තියාගන්න acute cholecystitis වල the inflammation, the acute inflammation will make it palpable. Right? And it can also, even without acute inflammation, it can cause something called a mucocele එකක් හදන්න පුළුවන්. What is a mucocele? Mucocele කියලා කියන්නේ mucus accumulation inside the gallbladder can distend the gallbladder. Right? The mucus accumulation inside the gallbladder can distend the gallbladder even if it is like inflamed. So එතකොට හිතන්න CBD එකේ එක gallstone එකක් තියෙනවා causing back pressure and causing obstructive jaundice, and cystic duct එකක් එනවා causing an accumulation of bile inside or mucus inside, leading to a distension of the gallbladder. So that is another instance where you will find the gallbladder being palpable. හරිද? What's third? Third එක තමයි this Miritzi syndrome. Miritzi syndrome is something they asked me in the long case as well, so you need to know what it is. Miritzi syndrome කියලා කියන්නේ congenital defect එකක් තියෙනවා in this cystic duct. හරිද? Cystic duct එකේ cystic duct එකේ can you see the my පේනවනේ මේ point කරන එක. So cystic duct එක නේද? This cystic duct එක සමහර අයගේ congenitally small. මෙච්චර දිග නෑ. This cystic duct ends like around here. So එතකොට what will happen? Let's say a stone got stuck in the mouth of the gallbladder. මෙන්න මේ හරිය. හරිද? That stone was big enough to compress the cystic duct and cause the gallbladder to gallbladder එක ඇතුලේ mucocele එකක් හරි මේ bile accumulate වෙන්න හරි මොකක් හරි එකක් වෙන්න it's enough. But the other thing is a stone එක, because the cystic duct is very short, that stone will also obstruct the common hepatic duct. එතකොට මේ මෙතන ලොකු I don't think I have a way to like anyway, yeah. So මෙතන ලොකු stone එකක් ඉර වුණොත් it will obstruct the cystic duct. It will also obstruct the common hepatic duct because the cystic duct is එක කොටයි. හරිද? ඒකින්ද it will I don't know why it crashed. Sorry. Okay. Okay, so this the common bile duct එක common bile duct නෙමෙයි cystic duct එකයි common hepatic duct එකයි both compress කරනවා in one මේ stone. හරිද? So that is Miritzi syndrome. So that's what I have written here. When the cystic duct is short, හරිද? it is near the cystic duct, it obstructs, it causes acute cholecystitis. At the same time, it also compresses the common bile duct or the common hepatic duct since the cystic duct is short. That will lead to obstructive jaundice. හරිද? ඔය තුන තමයි තියෙන්නේ reasons for gallbladder being palpable while it's while it's still due to gallstone. හරිද? What's the other way? The other thing is gallbladder being not palpable in the presence of obstructive jaundice, but it's still not due to gallstone. Again, still due to a carcinoma. What is that? That is when you are getting obstructive jaundice, the obstruction is somewhere above the level of the cystic duct. Cystic duct එකට උඩින්, somewhere here. මෙහෙ, කොහේ හරි මෙහෙ හරි එනවා obstruction එකක්. And the commonest reasons for that is a Klatskin's tumor. What is a Klatskin's tumor? Klatskin's tumor කියලා කියන්නේ a tumor at this bifurcation of the right and left hepatic duct. Methana tumor එකක් ආවොත් what can happen? It will obstruct the flow of bile through these ducts. But will it obstruct the cystic duct? It won't obstruct the cystic duct. So bile, whatever this thing is forming, it will freely flow out of the gallbladder, and gallbladder will not, it will not enlarge. What is it? So the gallbladder will not be palpable even though it's a carcinoma. මේක තමයි අනිත් exception එක. Okay. So that is Courvoisier's law. You should be able to explain those things because they love to ask this law in the long cases, especially SCQs and not පුළුවන්. හරිද? So obstructive jaundice is one complication of gallstones. What are the other complications of gallstones? Because this is the other thing that they asked me in my long case. So the other complication is this. What they can get is මෙන්න මේ දෙක තමයි මේක තමයි මගෙන් අහුවේ. Charcot's triad and Reynolds pentad. What are those? So that's another complication that you can get due to gallstone. What is that? That is ascending cholangitis. What is ascending cholangitis? Ascending cholangitis කියලා කියන්නේ when you have an obstruction in the CBD and you get stagnation of bile within the duct, ඒකට infection එකක් යන්න පුළුවන්. හරිද? That can cause an infection. So that infection can ascend and go into the liver. That's called ascending cholangitis. Cholangitis කියලා කියන්නේ infection of the this bile duct system. හරිද? So ascending cholangitis is one complication of gallstone. So that you need to know, and they can ask you how they present when they have ascending cholangitis. That is Charcot's triad. They will present with right hypochondriac pain, jaundice, and fever with chills. They can present. Sorry guys, I don't know why it's crashing. So okay. So yeah, even if you don't remember, even if you don't know, make a Q and A Reynolds pentad again Q and A, that's fine. Okay. Even if you don't say that, that's actually completely fine. Okay. Charcot's triad එක තමයි දැනගන්න ඕනේ. Right hypochondriac pain, jaundice with fever and chills. හරිද? So those are the main two complications. ඒ ඇරෙන්න the other complication is, if you want to remember, is the cholecystoenteric fistula එක මතක තියාගත්තාම හරි. හරිද? So those are the main stuff that you need to know about this topic. හරිද? Because obstructive jaundice part එක now, the obstructive jaundice and that related to gallstones is there, and I could have told you all about it, but since there's a separate class on obstructive jaundice, I don't want to, intrude on that. So this entire thing is about bile duct and obstructive jaundice due to gallstones, and how it presents and whatnot. And I will leave that to the person who's going to do obstructive jaundice next week. Yeah. The other thing is, you need to remember this part. ඒකත් කියලා දෙයි. The bilirubin metabolism, they can sometimes, like surgeons can go to these basics and they can ask those instead of asking the rest of the other stuff. හරිද? Okay. So in case that they have cholangitis, cholangitis තිබ්බයි කියලා හිතන්න due to gallstones. So what you have to do is that is an obstructed infected system, just like in make it in obstructed urinary symptoms. You have some urolithiasis, a renal stone or a ureteric stone causing obstruction, and on top of that they have an infection. ඒ වගේම තමයි මේකෙත් if you get an obstructed infected system, it's an emergency. So you have to immediately start them on the drugs that I mentioned earlier, and you have to go for an urgent ERCP to extract the stone or destroy the stone so that the obstruction is relieved. හරිද? So ඒ වගේ ඒකට the anyways you all will be taught this, but I'm just mentioning this in case. හරිද? Okay. හරි. So we'll get back to the SCQ. හරිද? Okay, so this SCQ. We'll get back to this. So a 50-year-old woman who presents with 3-month history of recurrent right upper abdominal crampy pain, which lasted for 2 to 3 hours. It's associated with nausea, especially following fatty meals, and she has no loss of appetite and no loss of weight. So what is the most likely diagnosis? Does anyone want to like put on the chat what is the likely diagnosis here? Someone like type no? No one wants to answer? I mean, there are like 7 people, 8 people who can say something. I'm not going to ask you all the answers for the other questions. I'm going to tell you all just the first question. Okay, never mind. I'll just tell. So the most likely diagnosis. Now this patient, the question doesn't mention a fever, right? It doesn't mention a fever. Yeah, exactly. Okay, good. Biliary colic. Yeah. So this is a biliary colic. Doesn't mention a fever and it only mentions the fact that the patient has presented with a right hypochondriac pain, lasting for 2 to 3 hours, associated with nausea. And I told you all it is associated with fatty meals. So why have they said no loss of appetite or loss of weight? Because this kind of this thing might be associated with, like, you might think of something like මේකක් වුණා. Head of the pancreas carcinoma හරි මොකක් හරි ඒක හිතන්නේ නැති වෙන්න තමයි they have written no loss of appetite, no loss of weight කියලා. Okay? So the first question, the answer is biliary colic. What is the most appropriate initial investigation to arrive at the diagnosis giving reason? So what will be that? That is, I told you all, it's ultrasound scan abdomen. What are the reasons that you're going to give? So you can say that almost 80% of the gallstones are radiolucent, which means doing an X-ray will not be useful in identifying this, but the ultrasound scan is considered the investigation of choice because it will show you will be able to correctly visualize the gallstones කියලා. And the other one what? The other one is the additional points I mentioned, that you can also look for features suggestive of acute cholecystitis. Just in case you might not present with fever, but you will always be looking for those features. You can say that in your ultrasound scan abdomen, I will also look for features of acute cholecystitis, like pericholecystic fluid collection, the gallbladder wall edema. And the other one is you can also say that you will also look for any dilatation of the common bile duct, just in case that the patient might have a obstructive jaundice or an obstruction to the duct system, which is something that you have to that I'll exclude prior to definitive management. That's enough. If you say all that, you're getting all 20 marks. Okay? So then they ask list 3 different complications that can arise due to the above condition, briefly describing the pathophysiology. Now, here you can actually say now condition, the above condition biliary colic එකක්. Now biliary colic itself won't give complications. It's the gallstones that gives the complication. So you can mention any of the things I mentioned. You can mention the obstructive jaundice mention කරන්න පුළුවන්. හරිද? You can even mention the acute cholecystitis as a complication, since it is actually a complication because they are dealing with biliary colic. It can lead to infection, inflammation, AD කියලා you can lead to acute cholecystitis කියලා කියන්න පුළුවන්. නේද? Pathophysiology එක තමයි basically that due to the gallstone obstructing the cystic duct, there'll be stagnation of bile within the gallbladder, and that stagnated bile due to the accumulation, it's a good media for bacteria colonization. So the bile, the bacteria from the gut can trans uh, can infect the stagnant bile and lead to an acute cholecystitis. Or you can even ඒකට add කරලා කියන්න පුළුවන්, you can even add empyema. You can say after the infection, if the pus starts collecting within the gallbladder, it can lead to empyema. So that's fine. Obstructive jaundice, you can say, because the presence of gallstones means that the gallstone can go through the cystic duct and get obstructed within the common bile duct, leading to stagnation of bile within the common bile duct and upwards, and the lead to the leakage of bile, not leakage, diffusion of bile or absorption of bile, the conjugated bile into the blood, and thereby giving rise to obstructive jaundice features such as yellowish discoloration of the eyes and skin, dark color urine, and absence of bile in the bilirubin in the small intestine, giving rise to pale stools and pruritus. ඒක ඊළඟට කියන්න. Then you can mention the other complication එක ලියන්න පුළුවන් අර cholecystoenteric fistula. You can say a large enough gallstone can erode and form a fistula between the gallbladder and the small intestine, and ultimately the gallstone can go through the small intestine, get obstructed at the ileocecal valve, and lead to small bowel obstruction. ඒක කියන්න පුළුවන්. You can even mention ascending cholangitis. If you were to mention that, it because the thing is ascending cholangitis කියලා කියන්නේ it's like obstruction ඇවිල්ලා then obstruction වලින් පස්සේ ascend වෙන එක. So even if you write that, that's fine. So yeah, those are the three complications. Enough. Okay. නේද? So you will get 30 marks more or less. If like 30 ම දෙන්න නැතුව වෙන්න ඉඩ තියෙනවා, but somewhere close to it. Then what is the definitive treatment for the condition mentioned? We mentioned. So that is, now this is biliary colic. The definitive treatment is a elective cholecystectomy. That's enough. එච්චරයි ලකුණු 10නේ. You just mention elective cholecystectomy. Alright. Then mention two important aspects in preparation of this patient specific for the above treatment. So what are the preparation steps that we did? One thing is we gave them prophylactic antibiotics. Why? Because there is a risk of them going into of them getting an infection. The biliary colic infection, any abdominal surgeries, usually we tend to give them these two in antibiotics, cefuroxime and metronidazole, to prevent an infection from either to have a gram positive and gram negative cover එකක් තියෙන්න, we give them pre-operative antibiotics cover එකක් දෙනවා. නේද? And we continue that for at least 5 days. And may okay, so the other one, then the මොනවද මේ the other important aspect in preparing the patient is that you have to do LFT. මං කිව්වේ LFT කරලා ultrasound scan එකක් කරලා ALP කරන්න ඕනේ to make sure that you exclude an obstruction to the common bile duct. හරිද? ඒක exclude karanna ඕනේ. That is exactly what they're asking here. If you are preparing the patient, you have to make sure that you have excluded a common bile duct obstruction to make sure that you won't be getting a complication like bile leakage from the stump of the cystic duct once they have finished with the surgery. Right? Because if you were to get obstruction there and you missed it and they do the surgery, අර clip එක පස්සේ pressure එකට වැටෙන්න පුළුවන්, or the stitches ගැලවෙන්න පුළුවන් because of the pressure of the back pressure from the obstruction, and the patient will get biliary peritonitis. හරිද? So two important aspects in preparation. එකක් තමයි the antibiotic coverage to make sure that you cover both gram positives and gram negatives. Actually, not gram positive and gram negative, mainly aerobes and anaerobes. Right? That's why you give cefuroxime and metronidazole. The other one is you do LFTs and do an ultrasound scan anyways to check for the CBD duct dilatation as well as check for the ALP levels to make sure that there is no um, underlying CBD obstruction. Right? And you mentioned why. Then last question is, what is the most serious specific complication of this treatment that we mentioned as well, which is the duct bile duct damage or the duct damage leading to bile leakage leading to biliary peritonitis. Right? Again, they are just asking a complication of the treatment. So you just mentioned that, that's fine. So the most serious, they're asking a very specific question here. They're asking the most serious specific complication of this treatment. So you can't write something like chest infection or bleeding. Because they're directly asking you whether you know about the bile duct damage leading to bile leakage leading to biliary peritonitis. හරිද? So ඒක තමයි මෙතන ලියන්නේ. Okay. So that essentially is actually all about the right hypochondriac pain, the cholecystitis, cholelithiasis, atica. හරිද? Now, if there wasn't obstructive jaundice lecture for y'all by someone else next week, I would have covered that too because anyways, tagged like it basically එකම lecture එක යන්නේ ඇත්තටම. But since there is someone, so I'll just leave that part to that person. So yeah, if y'all understood this much about this case, that's enough. You can get through your long case. You can get through if they ever ask another SQ like this. You can get through that. And rest of it is the MCQs වල අහන්න පුළුවන් ඒවා ඉතින් එතරම් covered more or less covered. Okay. So yeah, that is actually technically all I had to say about this topic. If y'all have any questions, y'all can ask me now on the chat or anywhere. Y'all want me to explain something because we still have a little bit of time left. Y'all want me to explain something else or yeah, I can do that. If not, we can stop. So if y'all have any questions, just ask. Y'all have any questions? No questions. Okay. Well, if y'all do have any questions, you can text me as well. I'm sure y'all know my number. Send me WhatsApp message if you need. If not, we can stop. And yeah. Okay then. All right. So I'll see you guys in my next listing. Don't know when that'll be though. I think it'll be next month. So yeah, if y'all have anything else that y'all want me to do, just mention on the chat or WhatsApp or anything. Otherwise, yeah, we'll stop for today. Okay, guys. Then, thanks thanks for listening. See you guys. Yeah, no worries, no worries. Okay, guys. Then, good night.